Good morning and welcome to this meeting of the Board of Directors for Lincolnshire Partnership NHS Foundation Trust. I'm Kevin Nokia, I'm the Board Chair. No preambles, let's get straight into this morning's agenda, which is quite busy, so I don't intend to hold things up. So start with apologies for absence, other than any that have already been notified. I don't think anyone needs to apologise at this point. Declarations of interest, if anybody has got any that they wish to add or amend, those that are already published, then please shout. If not, we will then move on to the minutes of the Board of Directors meeting held on the 5th of September. Has anybody got any points of accuracy or any other matters that they wish to raise from those minutes? If not, are our colleagues happy for me to sign those as an accurate record of that meeting? Yeah, a quick indication in chat will be fine. Fabulous, thank you very much. Schedule of actions, as usual, is pretty comprehensive, speaks for itself. So if anybody has any comments or questions on those, please let me know. If not, I will take them as noted. Chair's remarks. I don't have anything specific that I want to say that isn't already covered on the agenda and in the Chief Executive's report. The only thing that I will specifically mention is that this meeting is the last for our two current associate non-executive directors. VJ is with us. Cavill, unfortunately, I don't think is. So I'd just like, on behalf of the board, to put on record our thanks to you, VJ, and to Cavill for your contribution over the last year, which has been extremely valuable, and we'll be sorry to see you go, I'm afraid. So thank you very much. We will move on then. I don't have anything else specific, as I say, that I want to raise. So we'll move on then to the Chief Executive's report. Sarah.
Thank you, Chair. Good morning, everybody. I'm Sarah Connery. I'm Chief Executive here at the Trust, and I'm happy to be presenting my usual report. Just to go off on a bit of a tangent, the timing of the report meant, due to annual leave and timing of announcements, that I wasn't able to include anything around the budget. So it doesn't mention anything around the autumn budget announcements. Just my reflections on that. We haven't had a great deal of detail around the additional funding coming through for the NHS. As we spoke about previously at this board, there were a number of pledges made by the Labour government in their manifesto around mental health, around parity of esteem, around community services, around weights, around additional staffing. There was some detail around 26 million being available for mental health crisis centres. As you know, we have a mental health urgent assessment centre in Lincoln, and as a system we'd very much like to replicate in the east of the county. But as I said, no further detail available. We do know that the national insurance increase will affect our budgets in terms of the additional employers percentage being applied. And we're fully expecting some of the additional investment to be required to fund that pressure. But I'll keep the board appraised as and when more information becomes available. Also, which was too late for the report, there was the first reading of the new Mental Health Act bill through Parliament yesterday, I believe, and that's also something that we spoke about previously through this report. The current Mental Health Act being sort of 40 years old now and in much need of a refresh. So that's a really significant move forward, and definitely was one of the Labour government manifesto pledges. Also, just want to reflect myself, as well as Sharon Harvey, our Chief Nursing Officer and Professional Lead, as well as Di Bailey, one of our non-executive directors, attended the Social Work Development Day yesterday. And I will refer to it in a later report, but I just want to say we had a presentation from our international recruit social workers, and a number of us in this virtual room were there at their induction. But a year on, it was absolutely heartwarming to hear about how they've integrated not only within the trust, but also within Lincolnshire as well. And indeed, with some development that we've put through, some of them have already had promotions within the trust. And the general feeling, obviously, there are challenges around integration and moving from Kerala, but I think the trust did a really good job in terms of supporting those staff and helping them feel welcomed and a sense of belonging. So I just wanted to reflect on that as a real positive. In terms of the actual report itself, I have included, we had an East Midlands Mental Health Learning Disability Alliance event on the 9th of September. This was an all boards event, and unfortunate that due to clashes, etc., that not many of our board were able to attend on that day, but it was a really positive event, and general consensus that we would probably want to do it on an annual basis, and if we can get the dates booked in earlier, I think that will really help with attendance there. But we had some time in the afternoon to talk about future direction of the Alliance, lots of focus around patient safety and patient safety indicators, which I think ties in really well with our adult inpatient quality improvement programme. So again, keep you updated on that. And the purpose of the report, I do bring reports through my chief executive report on the work of the Alliance, but doesn't really bring it to life and probably can feel a bit dry for people. So I think, the live event really helped bring to life some of the work that we're doing together. And I know Tim was able to attend and welcome his thoughts as well and reflections on that. The only other thing that I'll really pull through, because as usual, there's quite a lot going on and quite a lot in the report, is around on the back of the Darcy review. Again, we've talked about it previously, is the sort of call to arms consultation for the new 10-year plan for health. There are a number of ways that we can have our voices heard, as individuals, as members of the public and users of service, as members of staff and people who work in the infrastructure of the NHS, but also as an organisation. So, Kevin, we have had this conversation, haven't we? And we've been invited to a regional event on the 28th of November. In terms of an organisational response, it's quite a tight time frame, and responses to the initial 5 questions are due on the 2nd of December. So I would welcome board's views on how we might want to pull that together. Obviously, people are free to complete on an individual basis at their leisure. But I think it would be really helpful if we could share those questions around, get people's initial thoughts. Myself and Kevin can then feed that into the 28th of November event. And then we can pull all of that together, hopefully before 2nd of December, and do one organisational response. But really welcome people's views on that. We have completed the matrix assessment around the community mental health services on the back of the Valdo Calacane review, and I know that was picked through in greater detail in Quality Committee, so I won't go into any further detail on that there. But I think it would be remiss of me not to mention our first ever Every Voice People Awards back in October. And I think, a resounding success, properly co-produced, absolutely led. I think our patient partners did a fantastic job. Lessons to learn, and I think we just keep moving forward and continually improving. But I hope it's something that the board can get behind as an annual event into the future. And a big thank you again to our comms and participation team for all they've done, not just around that event, but also our staff awards, as well as our annual public meeting as well, which, keeps us all busy through September and October. So I'll pause there, Kevin, and I'm more than happy to take comments and questions, but really keen that we have a think about how we want to respond around the 10-year health plan. Thank you.
Thank you, Sarah. Take comments and questions from colleagues. Tim.
Thanks, Kevin, and thanks, Sarah, for the prompt around the East Midlands Alliance. And so I've got a comment and a question. The comment around the East Midlands Alliance was, I mean, I found it a really enjoyable and productive day. And in particular, the Andy Bell gave a sort of great overview, which from my personal perspective, having that all set out in one place was absolutely brilliant for me. I think it's a really good sort of forum. I see it as really complementing, obviously, the Lincolnshire system where, you know, you've got those interfaces. But I think being in the same room with peers working in the same business with the same challenges and thinking about those solutions makes it all the more powerful. So very much appreciate the invitation because it did really bring it home to me, you know, bring it to life. So that was great. Thank you. My question really was around the investigation into the inpatient area, and having had a quick look through the report, etc. I mostly recognise the sort of findings and challenges that they set out in that. But I just wondered, from your perspective, was there anything that came over as a surprise?
No, absolutely not. I think it all resonated to a greater or lesser extent. I think, you know, certain organisations have different issues. You know, we're all at different places in terms of our estate, for example, and staffing challenges. So, and you know, within our own organisation, it depends on which ward we're talking about as well. And something else that was late for this report is the CQC State of the Nation, which again replicates a lot of what's coming through the HSSIB report as well. So I don't know whether others wanted to comment, but there was certainly nothing in there that was a surprise to me. But it ties into what we're talking about in terms of the 10-year health plan, I think, in terms of, you know, the barriers and challenges that we've got to delivering safe and effective, high quality care. So it all just ties up for me.
Okay, thanks, Tim. Chris.
Thank you, Kevin, and thanks, Sarah. I just wanted to echo what you said around the Every Voice People Awards. I was fortunate to be there and humbled by what we saw and heard. And I think, if anything, it's an illustration of what we're trying to achieve as a trust. I think the awards ceremony demonstrated that very powerfully, and it really was about co-production in practice. So huge congratulations to everybody involved, and thanks. And I think we should be very proud of what the trust is trying to achieve. Thank you.
Thank you, Chris. Very emotional day. I think we'd all agree.
Thanks, Chris, and completely agree with that. It was a fantastic day. And although you mentioned that there are lessons to be learnt, Sarah, I think that's a point of detail given, you know, the kind of overall impact and success of the day. So, you know, as I say, absolutely echo what Chris says. Di.
Thanks, Kevin. Thanks, Sarah. I just wanted to go back to the mental health inpatient settings and the HSSIB report. Absolutely echo what Tim was saying. When I looked at the report, and admittedly I've not looked at it in detail, but from what I can see, there was that sort of focus around settings in terms of workforce and buildings. But I suppose what I'd hoped there would be more about was what they found in terms of any clues around therapeutic models of care, and that seemed to be a bit missing. So I just wondered whether you'd got any Any more thoughts on that, really, in terms of where that might take us? And also, I guess what I wanted to understand is where that work will be picked up, because I absolutely get that we need to cross-check with what we're doing with the transformation programme and the strategic delivery plans, but I suspect there will be some cross-cutting themes that will go beyond quality committee, and it's just really where we pick that up as to make sure that we join the dots, I guess.
Yeah, thank you, Di. And I think it's beyond inpatient as well. I think those, so there's lots of work that's going on around inpatient from a quality improvement point of view. A little bit of SDF funding, for example, and national frameworks. But in terms of community, sadly, on the back of the Valdo Calican case, we're now sort of attending to that as well. And for me, it's very much about our philosophy of care work, which is also mentioned in the report. And I've pulled together a very high level framework around that, and then I've asked Girish Kunagiri, our medical director, then to take that forward. So I think board development session will be a good place to start to familiarise that framework and to shape it more. And then we'll take that through our governance structure, and then it will be an ongoing report coming through to the board around that. But it is unpicking and framing, for all of our services, really, in terms of our philosophy of care, not just for inpatient. So yeah, we'll feed that through into the board development session agenda for the new year.
Okay, great, thank you.
Thank you, Di. Sarah, there's a kind of intersection here, isn't there, of what we do to kind of redesign services in order to best live within our means, and how we improve the patient experience by refocusing on our philosophy of care, and how all of that feeds through into the kind of culture around the delivery of services. So it's quite a complex set of interconnected issues, and we just need to make sure that we bring that out effectively in that board development session and in the further consideration that we give to all of this.
Yeah, agreed.
Thank you. I've got Sarah Whiteman next.
Thank you. Sarah, with respect to the 10-year consultation, I just wondered what thoughts you'd had already, and then building on what people have said about that fantastic Patient Voice Awards, I was thinking perhaps we should have maybe a couple of workshops, one involving service users to get their thoughts, us synthesizing what's been proposed and our ideas, but working with them. And then in the afternoon, perhaps the board coming together, perhaps even involving the Council of Governors to pull it all together and thinking maybe we should be, or I don't know if it's even possible, to be creative and have some video inputs, because I think mental health is so important, and we're doing some of the things we're doing are so good, and the need to secure resource in the future is so important that this is a big opportunity for us.
Yeah, thank you. And I know NHS England are putting on sort of engagement events and trying to, certainly this is the first time that I've seen the how being as much important as the what for NHS England. So yeah, I'll definitely consider how we're certainly inviting our staff and patients to engage, but we'll have a think about how we might make that a bit more of a conversation rather than just sharing a link around. My reflection so far is that when this was initially shared out with chief executives, it was discussion around this is more of a health plan, and it has now become more of an NHS plan rather than a health plan. So I think that's something that we might want to attend to in our feedback, that as a health and care system, we know that keeping people well isn't just about what happens in NHS services, and how do our government departments work effectively together to push health rather than treatment, because one of the 3 pillars is sickness to prevention, and that's certainly something that we're trying to achieve around our mental health, dementia, learning disability and autism alliances. Let's think about people as a whole person. Let's work in a multidisciplinary way. The questions themselves are very much framed in terms of organisational response around what are the challenges to delivering hospital to community, analog to digital, and sickness to prevention. So, but there is also opportunity for people to share ideas as well. And if you pop on the change portal, there's some interesting ideas there in terms of how we might want to see the NHS transforming into the future. But for me, it's, and I've said this previously, the capital programme and machinery in the NHS needs significant overhauling to ensure that as a foundation trust ourselves that we can manage our resources more effectively and be more responsive to what Lincolnshire needs. That's certainly a big one for me that we've talked about a lot here at the Trust. But no, thank you for your question and thank you for the idea there. I think that could do with a bit of thought.
So I think, Sarah, what's really important here is that the government is going to be absolutely kind of deluged with responses to the consultation, and we want to say something that is likely to be heard, and offers a kind of distinctive voice. So I think we need to take some care over how we present a response, and to make sure that it says the 3 or 4 things that we think are really most important, and says it in a way that models how we might want the system nationally to develop over time. So I think having some element of co-production in that to kind of reinforce the sort of behaviours that we would like to see, I think is important. But I also think it's important that we don't try and say something about absolutely everything, because it's one response in thousands, and if we want to say something that is going to make people sit up and take notice, it needs to be really carefully framed and really powerfully presented. Sharon.
Thank you, Chair. Sharon Harvey, Chief Nursing Officer. I just wanted to come back to Di's point and elaborate a bit, if that's okay, to provide some assurance to the board. We continue to review any new guidance that comes out, especially national guidance or advice in as part of our adult inpatient quality improvement work. So I'll ensure that the HSSIB report is considered both as part of that quality transformation to make sure we're not missing anything, but also for assurance through our quality governance route, which reports through to Quality Committee. And in terms of the models of care work, the wider inpatient model of care and national guidance has got some real clarity in it and visions, exactly as Di's mentioning, and some clear expectations for us as an organisation. And just to assure the board, we're linked into those programmes in a whole range of levels, at ward level through culture of care, but also through a lot of their different programmes of work, and to try and learn from other organisations. What is a challenge for us and is going to be really key is that SDF funding that Sarah mentioned, because without that, we're going to struggle to have resource and management of this really big and very important programme of work for us as an organisation. But there is a lot we're already tapping into, so I just wanted to provide that assurance and reassurance to the board.
Yeah, thanks, Sharon. That's really helpful. I don't see any more questions or comments from colleagues, so thank you very much, Sarah. Thanks as ever for providing a report that is a really useful whistle-stop tour of an awful lot of activity that's going on, and I know how difficult it is to get the balance right between being comprehensive and producing something that's slightly longer than War and Peace. So thank you for that, and thank you for getting that balance right.
Thank you. So we'll share around those questions from read the 10-year plan and then hook back round after the event on the 28th, if that's okay then, Kevin.
That sounds absolutely sensible. Thank you, Sarah.
Thanks, Kevin.
We'll move on then to item 2.2, which is the Board Assurance Framework. Karen.
Thank you, Kevin. I'm Karen Scott, Trust Secretary. And I'm pleased to present the board assurance framework. This is the board's quarterly review of its assurance framework. And as set out in the paper, I hope quite clearly, describes the very robust scrutiny and challenge that the document goes through by each of the respective board assurance committees and then by the audit and risk committee. It does also list each of the forums that it has been presented at. So just particularly to pull out, since the board's last review of the document, whilst each of the committees obviously does make some amendments, and those are all highlighted on the document so that track changes can be seen prior to the board's decision to approve or otherwise. But in particular, the best use of resources has carried out a really thorough review of what was previously one risk, describing some very key elements of that element of the trust strategy, and was not necessarily so clear, and it has now been broken down into individual risks to describe each of those areas more clearly and transparently. So I hope that board members will acknowledge and agree that that's actually a much clearer way of describing that. So nothing else specifically to flag at this stage, Kevin, although in preempting for the next item on the risk report, I did want to just make mention that for those that have read the two side by side, you will probably have noticed that there are a higher number of risks recorded on the organisational risk register than that are necessarily reflected, or some of the risks that are reflected on the board assurance framework. And that is purely down to a timing issue and the governance process that the board assurance framework has to go through. We wouldn't make amendments prior to it getting to the next stage and for it coming to board when that's not already had some scrutiny and challenge. So the organisational risk register is much more up to date. So I just wanted to make that clear in advance, Kevin. Thank you.
Thanks, Karen. Any questions or comments from colleagues on the board assurance framework? Tim.
Kevin, so Tim Harry, non-exec director. Yeah, just to echo your words, Karen, and a big thanks to you and your team to help to sort of develop this. And I think one of the key things that we talk about is that this is a living document. It's not something that we want to put on a shelf, you know, and it gains dust. It's got to mean something. And I just think, thinking ahead, an example around that is that the challenges around vacancies has changed in terms of, you know, affordability, etc. There's a new tension and a new challenge in that, and there are implications across finance, quality, and people committees around that. So I think when it comes to the next review, I certainly will be looking at it with a slightly different lens in light of that, and it'd be interesting to see how each of the committees and the BAF develops in that sort of particular area. That was just a comment. Thank you.
Thanks, Tim. I might have come on and comment a bit about that when we come to the next item on the risk register. You know, that is a comment on the changing nature of some of the organisation's risks, but I won't preempt that. I'll cover that in the next item. Ian.
Thanks, Chair. Ian Orrell, Chair of the Audit Committee. In a sense, I just wanted to echo a couple of points that have been made by Karen and indeed Tim. First of all, the work that Karen's team's done, I think, is been very good in terms of getting us to this position. And as Tim said, it's and I agree, it's very much a living document, and it feels like that as we're going through. I do mention later on in the agenda that it went through the audit committee as indeed Karen has said already. And I think one of the things that is certainly helpful to me as the audit chair is to have chairs of the other committees on that audit committee meeting. So not only do I see a document, but I've got the characters that are responsible for relevant parts of that document live in the meeting. And I don't think that should be understated, really. So just a comment. Thank you.
Thanks, Ian. I don't see any other questions or comments on the board assurance framework. So thank you very much for presenting that, Karen. And note the point about it that Tim rightly raises, that this is a a living document rather than a document of record, as it were. So I understand the fact that this will be further revised and refined. So we'll stay with you, Karen, for the next item, which is the organisational risk register.
Thank you, Kevin. So as I alluded to earlier, this is the Trust's organisational risk register. And at the last board meeting, I took an action away to look at how we might review the formatting of this report so that it was a little bit more meaningful, or drew out some of the key points for the board, rather than just a list of numbers of risks. So this is just a very early first attempt at doing that. It does set out in the front sheet that actually link to that work, and I'm hoping that in due course this will obviously be very iterative, but with the advent of a new system coming online at sort of midpoint next year in the Trust, we will have access to a much more analytical tool that will assist in some of that, and I hope support some of that presentational formatting. But I hope that at this point, by collating the risks in terms of the divisions, the ambition is maybe to take that one step forward and actually link it to each of the pillars within the Trust strategy. But I hope that it's a first starting point, and that directors acknowledge that, but would be really keen to hear any suggestions or comments about what they're seeing in front of them now. Other than that, I haven't got anything specific to draw out, Kevin. Thank you. Happy to pass on to any colleagues that want to talk about any specific risks, or respond to any queries about individual risks. Thank you.
Thanks, Karen. Sarah.
Yeah, just thank you. Just want to thank Karen for working on the report. I feel it's much more insightful and digestible and readable in the way that it's presented. So it was just say thank you.
Thanks, Sarah. I'm going to offer a slightly different comment, Sarah, although I think that the report as it's presented is more readable. I actually think it's probably less useful, and without any kind of framing of the risks with current mitigations, I think it makes it much harder for the board to engage with the reality of those risks and the organisational response to them. So for me, I have to say, I don't think the kind of more stripped down version of the risk register works for what the board needs it to do. So I'm going to suggest this, that I think we need to take a step back from the kind of operational detail, as it were, of the risk register, and do 2 or 3 things. And I'm looking at the chair of audit committee here, Ian, because I think this is a job for audit committee to take on. So what I'm going to propose that audit committee does is to work through the risk register as it currently is, to make sure that it contains the right risks, That is the risks that pose the most significant issues corporately for the organisation as a whole, to make sure that we've got those risks as well and accurately described as we can, because I think that some of the risks still are a little bit into the long narrative kind of tendency, and maybe aren't focused enough. I'd like Audit Committee, please, Ian, to review the current risk scores and provide assurance to the board that, so that's on two things, that we've got the right risks and that we've got the right scores for those risks. Because I do slightly worry that we've got risks that for which we've got mitigations, and where those mitigations don't seem to make any difference either to the likelihood of the risk materializing or the impact of it if it does. So I'd like Audit Committee, please, to have a go through that with, in some detail, to make sure that we've got the risk scores right, so that we are sure that we're focusing on the right things. And then finally, I'd like Audit Committee to provide assurance to the board that we've got adequate mitigation in place for each of those risks. So that's, I think, four things. And I know, as it were, Ian, that I'm asking Audit Committee to do this, on the, in addition to your normal kind of agendaed business, but I'm asking you, please, to make sure that we've got the right risks on the risk register, that the risk descriptions are appropriately accurate, that the risk scores are right, and that we've got appropriate mitigation in place for each of them. So that's about providing assurance to the board around controls as much as anything else. So that's what I think we probably need to do if we want to have a better focused risk register that aligns with the kind of discussions that we need to have around the organisation's key priorities. Ian, does that make sense? And are you happy for Audit Committee to pick that up? Ian?
Yes, absolutely, Kevin. I think it's quite difficult to, not that I want to, but disagree with much of what you've said there, because in a sense, what you're saying is fairly standard stuff in terms of what we'd want in terms of grip and control and so on. And I think the only thing I'd add, I think I'd be confident that we can come back with positive answers to most of those things, but we need to demonstrate that. So yeah, absolutely, we'll take that on. Thank you.
Thanks, Ian. And Karen, I wouldn't, as I think wouldn't want you to take that as a criticism of where we are, because this is in every almost every organisation that I've been in, getting the risk register right is an ongoing. It's a bit like painting the Forth Bridge, and if you're not careful, the risk register just turns into a paper exercise that doesn't properly reflect what we're doing as an organisation and where we want our priorities to lie. And I think that what I'm asking Ian to do is just to give it a bit of a kick up the derriere, just to make sure that it is doing exactly what we want it to do. Karen?
Yeah, no, absolutely, Kevin, and I quite the contrary. I welcome the bringing it into a sharper focus. I think that will really help and lend itself to the work that is going on in the background and support that. But I also wanted to add that the next paper that we're going to talk about is the board's risk appetite, and I think that will help to inform that conversation, because that is much more current, and just in the background to let you know that there is currently underway a review of the Trust's management of risk policy, so that risk appetite will also inform the policy. So I think there's a number of pieces of work that we need to join up the pieces, and actually audit and risk having that clear responsibility or that task, I think will be really helpful. Thank you.
Good. Thanks, Karen. Colleagues are happy to move on then. We will do so and move on to item 2.4, which is still with you, Karen, and it's a review of risk appetite.
Yeah, thank you, Kevin. So I hope that the paper is straightforward. I'm going to take it as read. As board members are very well aware, and I appreciate the input from everybody in getting to the point that I'm able to present this paper today. There's been work by everybody involved in the board to contribute to this, and the thinking, and it sets out in the paper about the board development session that we had more recently to get to this position of a proposed and an agreed position as a board moving forward. So really don't necessarily want to draw any more than that out at this stage, Kevin. Really just seeking board's approval formally to actually progress with this and actually instigate this new risk appetite and replace the one that we're currently adopting.
Thanks, Karen. Just by way of context, so this has gone through quite a in-depth and detailed discussion at board development, followed up by a series of followed up offline, as it were, with bilateral discussions, contributions to shaping the document. So it's had a number of coats of looking at, as it were. So any questions or comments from colleagues? Di.
Thanks, Kevin. Di Bailey, non-exec director. I just wanted to thank Karen for this and the work that the team have done. And I just think it's been really helpful building on that board development session that we had when this was first discussed. I suppose the question for me is, in a number of areas, our risk appetite is high and open, and in some instances, we're saying that we're going to be brave and are eager to take some risks. And I just wonder how this sits alongside the risk appetite within the system in terms of whether we anticipate we're going to be in line or out of kilter, particularly around some of those areas where we are saying we're high and open, or indeed eager to be brave and do things differently in future.
That's a good question, Di, and one to which I don't know the answer. Sarah.
Yeah, we did touch on this at our last integrated care board. The integrated care board risk appetite at the minute is cautious, I think, on all of the strategic levels. So I think it's something for our all board session that we can maybe keep a conversation going around it. And I think that's sometimes why things take the path that they do in terms of us trying to change and transform services. So I'd say that's one for the all board session.
Thanks, Sarah.
And I also think, Sarah, that risk appetite is situational, isn't it? And I wouldn't be particularly exercised if our risk appetite was different to the ICB's, because the ICB isn't the system. The system is more than the ICB, and it may well be that organisations that make up that system have different appetites for risk because they're in different situations. Sarah, did you want to come back on that?
Yeah, no, sorry, that was kind of, a lot of our system partners don't have risk appetites, so you can't engage in a conversation around it really. So it's the framework that you use as well as the situational response as well. So it's a tricky one to get it all in alignment, but I think a conversation would be helpful.
But I think my point is that it need not be in alignment, and one might reasonably reach the conclusion that as a result of implementing the ICB's target operating model and the things that we need to do in response to that, we will inevitably have a raised appetite for risk because there is some risk inherent in what the ICB is asking us to do.
Yeah, sorry to labour the point. I'm probably not explaining myself very well. It's the framework, not the actual where you stick the tick in the box, if you see what I mean. So a lot of the organisations who are our prime stakeholders don't even use that framework. So it's how you have a. Does that make sense? Sorry, I didn't explain myself very well.
I know that's probably me being dense. So
no, not at all.
Thanks, Chris.
Thanks, Kevin. Chris Wright, non-exec director. I just want to commend Karen for pulling this together in such a clear way. I think it's a really good piece of work. And to the previous conversation, you know, obviously we have to interface with the wider system and players, but it's really important that we align this appetite in our own organisation. And so the challenge for us now is, having set out our approach to risk, that we flow it through the organisation and everybody in the organisation understands what it means for them.
Yeah, completely agree, Chris, on both points. Tim.
Yeah, so Tim Harry, non-exec director. Yeah, my comment really echoes what you said, and I do think back, because when John Turner did come to one of our development sessions, risk appetite was raised. So I think he knows that it won't be totally aligned. We will have a different view on risk appetite. And for me, what's more important is actually not alignment per se, but understanding of where each other's risk appetite actually is, so we understand where each of us is coming from. Thank you.
Yep, completely agree, Tim. Karen.
From a very practical point of view, Kevin, it is good practice that the board reviews its risk appetite on an annual basis. So time goes incredibly quickly, but then so does the environment in which we operate. So, you know, given that we're just about to potentially adopt a new risk appetite, you know, it will be no sooner have we sort of got this embedded that we should potentially be reviewing it, and things will change. So it's not to say this is cast in stone, and I think it should be reviewed regularly.
Yeah, completely agree. So Karen, thank you very much for pulling it together. As Chris says, it's a exceptionally good piece of work and very clear. We need, as a board, actively to adopt this. So can I ask colleagues please to indicate whether or not they're happy so to do? Excellent. Thanks again, Karen. We'll move on then to the next item on the agenda, which is the highlight and exceptions report from Quality Committee. Sarah.
Thank you. Sarah Whiteman, non-exec director, new chair of the Quality Committee, having taken over from Di Bailey. So at our Quality Committee on the 3rd of October, we discussed three main areas of interest at a high level. The first was the Valdo Nottingham Learning and its application to treatment-resistant pathways. We discussed this in relation to the work that we need to do within the trust and the system, and how it relates to the BAF, as we discussed previously in this meeting. We talked about patient experience on the Vales ward, which was a proactive piece of work brought by the chief nurse. And we discussed some of the issues there that included things like the use of blanket restrictions, patient participation in ward rounds, and food, which is a recurrent topic. And we also, the third thing was a length of stay deep dive, some of which were quite eye-watering in the amount of time some patients have spent with us, when the target is around, I think our target length of stay is 30 days. Girish, Sharon, I'm looking at you, and there were some people who had literally been there for over 1 year. So we're going to do some work as a result of those discussions, which will be brought back to the Quality Committee. In addition, operationally, we discussed the need for the Patient Safety Incident Reporting Framework, PSIRF, to be even better embedded in the Trust. So that's going to be brought back next meeting. And we reviewed our terms of reference to include attendance from the Chief Operating Officer. So next meeting, leading on from what Sarah and I have said about the cross-cutting themes and the need for us to keep on top and make sure that we're all joined up, we will be talking about how PSERF is and will be embedded more effectively, even more effectively, in the trust work. We'll be looking at the treatment-resistant psychosis pathways and getting regular feedback on that. And we'll be hearing a case review of the learning from a patient who had to be segregated for a while. And that concludes the highlight report. Thank you, Chair.
Thank you, Sarah. It's very helpful. Any colleagues with questions for Sarah? Girish.
Thank you, Chair. I'm Dr. Girish Kunigiri, the Chief Medical Officer. Just extending to what Sarah was talking about. I mean, later we will hear that there is a significant piece of work which is currently in place, with regard to understanding and trying to manage, the delayed discharges in our organization alongside the length of stay. Thank you.
Thanks, Girish. Sharon.
Thank you, Chair. Sharon Harvey, Chief Nursing Officer. I just wanted to provide one additional update in relation to the incidents in Nottingham and our learning. We're convening a system learning event following recommendation from the ICB board, but also agreement at our quality in the process of coordinating that, and of course LPFT are front and centre for that event. Thank you.
Yeah, that's helpful. Thank you very much, Sharon. Okay, so if there are no further questions or comments, Sarah, excuse me. Excuse me. Karen.
Sorry, just before you move on, Kevin, just point of accuracy, can I just please seek the board's approval to the new terms of reference, although only slight revision? Thank you.
Okay, thank you. So before we move on then, if colleagues could indicate whether or not they're happy to approve the new terms of reference, and if so, we will then move on to item 3.2, Sharon, which is you and the safeguarding annual report.
Thank you, Chair. So Sharon Harvey, Chief Nursing Officer. The purpose of this report is to assure the board, the public and safeguarding partnerships that the Trust is complying with its statutory requirements and sharing lessons learned along the way. So it's here for decision by the board and will then be published on our Trust website. I'll take the paper as read. We've taken the feedback from last year and tried to make the report succinct but clear, and any further feedback on that very welcome, and happy to take any comments and questions from colleagues.
Thank you, Sharon. Tim.
Yeah, Tim Harry, non-exec director. Sharon, thanks very much for the report and the assurance that it gives. It's really just a comment. I just did not appreciate the number of the level of interactions required. So I'm in awe of the team in being able to sort of handle all those. So yeah, thank you for that. That was a real eye-opener for me. Thank you.
Thank you. Could I just quickly come back on that, Kevin?
Yes, of course, Sharon. Yeah.
Our team are incredible, our safeguarding team, as are our safeguarding champions across the Trust. As colleagues will know, we've had some significant capacity challenges and some long-term sickness in the team, but they've kept going. I'm really, really proud of the safeguarding team. So thank you, Tim, for making that point. I really appreciate it. Thank you.
Thanks, Sharon, and just absolutely echo what you've said there. It is an outstanding team doing really, really important work, and I think the board appreciates that. Amy.
Hi, I'm Amy Beaton. I'm Chief People Officer at the Trust. Sharon, I think in terms of your initial inquiry as to the improvement on the report, I thought the report was really clear and got that balance of detail. right. So really welcomed this. And as Tim has just said, it's clear why in the report it does reference capacity within the team, looking at that. But actually, I wasn't sure that it did reflect all of what the team did, because I couldn't find in the report reference to the services it offers in terms of staff. And I know the team do work closely with Staff Wellbeing Service and do provide that intervention. So I just wondered why that was the case. Is there a reason for that, or whether it was an omission?
Thank you, Amy. It's a really helpful challenge. So it's deliberately not mentioned, in part because of the sensitive nature and the amount of staff that we sometimes support, but also because often we're very indirectly working with staff, that sometimes that would be really difficult to quantify. Just to assure the board, we do have a domestic abuse policy for staff, which is excellent practice by the organisation for us having that. I think we could look to broadly reference it in future reports if the board would like, but I am reticent for us to put very much detail in because of those other bits I mentioned. Although I do wonder, Amy, whether it's worth us having a separate conversation around through our other reporting in the more people routes around the health and safety of our staff at work and other bits, whether there's things there where we could focus on that a little bit more. But it's the how, isn't it, given the sensitivity of how we're supporting some of our staff. But thank you. Does that answer that?
It does, and I welcome the conversation outside. It's just I felt like, you know, it is a level of work they provide, and we're not seeing that. So absolutely happy to explore, get the issues you've raised.
Thanks, Amy. Chris.
Thank you, Kevin. Chris Wright, non-exec director. 2 points. Firstly, Sharon, I think this report is a significant improvement on what we previously presented. So thank you. And secondly, and picking up really on Tim's point, and I say this with a degree of caution and awareness of the sensitivity of safeguarding, but one of the things I think that this report highlights, as Tim suggested, is this complex interface between us and the system, the wider system involved in ensuring children and vulnerable adults are properly safeguarded. And this point, I don't mean it in any way to be misunderstood, but one of my concerns around safeguarding per se is where the process or where impact becomes subservient to the process. And the evidence suggests that over the last many years, whenever there's a tragic incident associated with safeguarding, the response tends to be a lowest common denominator response, which is building more process and bureaucracy and systems. And of course, we need to ensure that things are done properly, but we mustn't allow that to get in the way of people doing the right thing, as opposed to doing things right. Thank you.
Thanks,
Is it okay
Chris.
if I just comment back on that?
I was going to invite you to, Sharon. Go on.
Thank you. I absolutely agree. And the approach that we take as an organisation around our safeguarding champions is for exactly that reason, so that we've got people that really get it from a safeguarding perspective, but not in terms of, they do need to know our policies and our processes and our learning, but actually really get it in their core about doing the right thing for and with people. A lot of the conversations that I have with the safeguarding team and they're escalated to me are often the policy says this, however the right thing to do for this person is this, and this is the reason why in order to safeguard. It's the spirit of safeguarding that we end up talking a lot about, and that's one of the reasons I'm so incredibly proud of the safeguarding team, because they're really challenging themselves to keep that at the core of everything they do. And the additional challenge for them that's been set in line with our strategies around how they also consider human rights more strongly in everything they do as well. But again, the spirit and the ethos of what that really means, of course we need to follow the legal frameworks. I don't want that to be misconstrued, but it's about that doing the right thing to safeguard our people.
Thank you, Sharon. I think that that fits really well with the sort of organisational culture that we've tried to promote as a board, which is, that we should do the right thing, not just develop an action plan or a strategy or a plan or whatever. It's the the human interaction that underpins all of that, the culture that underpins all of that, that's more important, or at least as important. So thank you, Sharon. It's good to hear. Sarah.
Thank you, Sharon, for a great report. And it's building on Tim's point, really, about some of the statistics in there. But I think from a board point of view, it would be really useful to see some more, like a bit of how it's changed over time as well, in terms of not just from a capacity point of view. I mean, they're a phenomenal team, but also just for the trust to understand how that demand is changing over time as well. So I don't know if that's something for next year's report to put some more data points in. Thank you.
I'll make a note, and if we put that as an action to pick up in future ones. So I think the other thing that will be interesting to see is the different types as well as the numbers. I know anecdotally there's a lot more around neurodiversity and some of our protected characteristics, but I don't think we've fully referenced that, or we might not fully have the way of reporting on it fully yet, because that's obviously in line with our other areas that we're focusing on. So thank you. Yes, I will do that.
Thank you, Sarah. Thank you, Sharon. Girish.
Yeah, thank you, Chair. Dr. Girish Kunigiri, Chief Medical Officer. I just wanted to reiterate a couple of things which have already been discussed. One is, because this report is in the public arena with regard to the Amy's point, I would prefer I would prefer not to include too many details with regard to the support whatever staff receive, first thing. And the second thing is with regard to the comment from Chris Wright. I think as an organization, it is always not easy in terms of how we balance, what is right, which is focused on the outcome and resolving the issue versus the policies and the procedures which we'll have to follow, because if things go wrong, there is a lot of scrutiny, why things have gone. And the first thing, people generally ask is, what is the process and policies we have, and whether we have followed those processes and policies. So just for the board to be aware of, which I think they are already. Thank you.
Yeah, that's absolutely right, Girish. We need to have both, don't we? We need to have the right policies and procedures in place, and then a culture that gives life to those policies and procedures. And I think personally, I think we need to attach equal importance to both of those limbs. I see Sharon nodding, and I'm always reassured when Sharon nods. Okay, thank you, Sharon. That's really helpful. Do we need to sign that report off? Is there a decision there that the board actively needs to take? Yes.
Please. But it's for decision for approval and going onto the trust website, please.
That's what I assumed. Thank you. So people could indicate that they're happy to do that, and they've beaten me to it. So that's great. Thank you very much, Sharon. We'll move on then, and I think it's you, Girish. Next, item 3.3, the Learning from Deaths report.
Yeah, thank you. This is a quarterly report to the board in terms of learning from deaths. This is something which people are already familiar with. This is to provide assurance to the board that we have a robust process in terms of identifying, investigating, as well as learning from the deaths which unfortunately happened. And this is for the patients who have died during their care in our service, or in the last 6 months, after they have been discharged from the services. So there is a robust process by which we identify these patients on a daily basis, and they are discussed in detail on a weekly basis as well. And we have a number of ways by which we categorize these people into different categories based on which we investigate these patients. So one is I think one is in terms of whether these patients need to be reviewed based on what is called as the patient safety incident review, or whether they need to be investigated based on the framework of mortality case review, which is more like a clinical desktop review. And the panel is constituted by the multi-professionals involved. And those patients who unfortunately die because of autism or learning disability, we have a separate process which is led by the ICB, and we are actively part of it. You can see on the report that in terms of the trends for all the 4 divisions, we are generally within the trend. With regard to adult community, you can just see that there is a small spike, which is because of the data collection. We have included the deaths in IAP services as well, because of which there is slight upward trend. But I can assure that that figure is definitely within the trend. One of the things in the past, the board did ask whether we can benchmark with our neighboring organizations to see whether we are in line with them or whether we are outliers. We have done some work with regard to that. We are not able to benchmark because the way the data is collected in different organizations and the way they are categorized is very different. And as a result of that, we will not be benchmarking like to likes, and there may be some issues related to that. So that's why we are just focusing on our own data like others do, but the trend is very helpful. And one of the things the board is interested is what kind of learning opportunities we have. I did notice some of the emails from one of the NEDs related to the recent incident as well. I need to assure that we have a robust quality improvement process in terms of our learning. Once the deaths have been reported, once they have been investigated, there is a process in terms of sign-off, and the summary of learning from all deaths is reported on a monthly basis, which then goes to all the divisions and then to the clinicians. With regard to the deaths which happen in the community related to autism and learning disability along with mental health issues, once they are discussed at the ICB level, which is called as the leaders group, that is then fed back to the mortality surveillance committee, which I chair, which is attended by all the quality leads, and from there it goes to the divisions and to the clinicians. We also have a bulletin which is circulated periodically, which is called as the Safety Matters and Excellence Matters. In the last few months, we have also started using thematic review based on the PSERF framework, which obviously we are embedding in our organization. And this has helped in terms of looking at systemic contributors for some of the incidents. So that will be helpful, in terms of our learning. So as a whole, I can assure that, as an organization, we have a robust process in terms of identifying and managing people who have unnatural deaths, and we have a robust process in terms of our learning. Thank you.
Thank you, Girish. Sarah Whiteman.
Thank you. Girish, I think this is a really good paper, and I think the analysis that you and the teams undertake is really good. And I think the learning implementation is clear. I think the communication strategy, so just an observation and then one question, please, Chair. The communication strategy within the trust, I think, is absolutely excellent. I think the bulletins that come out to us and generally are really of a good standard and better than I've seen anywhere else. And I think if I don't know if other people agree, but I think they really are helpful, constructive, transparent, and really good. My one question is, are sufficient resources allocated to address the identified issues?
Thank you. Thanks for your compliment. I think in terms of the adequate resource, I mean, to be honest, from the patient safety team, I mean, one of the things what always comes up is in terms of involvement with by all the different professionals, so that the learning is multi-professional and people look at the case from different angles. I mean, it is more from the medical input, which has been always raised with regard to being a part of the review as well as the part of the investigation. So other than that, my patient safety team have not alerted me anything different unless Sharon has heard something different from me. Thank you.
Thanks, Sarah. Di.
Thanks, Kevin. Thanks, Girish. Di Bailey, Non-Exec Director. Girish, I just wanted to ask, given the focus of the trust strategy around healthy population, whether there is any way in future that we could perhaps add some information into this report from that perspective, really. I think I absolutely take your point about benchmarking with other organisations because we're comparing apples and pears, and a lot of the deaths are, people who've had contact with our services 6 months ago, and obviously there hasn't been an investigation. But I think in terms of the strategic aim around understanding our data in that kind of public health arena, it might be helpful to have a perspective that looks at this from a sort of healthy population perspective, so that we can contextualize a bit more, I guess, this population that we are seeing within that wider context.
Thank you, Di. Can I just clarify? Are you talking about the deaths which happen beyond 6 months of discharge?
Yes. Yeah.
Okay, that's a good point. I will go back and then see what data we have related to that, and whether that is an exercise we may have to do, and how easy it is for us to do. Yeah,
and it may be, I mean, I don't know, it may be that data is being collated elsewhere, but I think it would just, in terms of just giving us a context of the population more broadly, I think that might be quite useful.
Yeah, in terms of the data, just for the board to be aware, we look at the SPINE, which is the national database, all the deaths which happen on a regular basis, for patients who are under our care or who have been discharged. Probably we may have to extend that, filters to what you're talking about. And the second thing is, we do get the data from the police, local authorities, coroners, GPs. We try to pull all this so that we don't miss any of them. So it's a very rigorous process. It takes a lot of time from our team particularly to look at the SPINE, because it doesn't specifically talk about mental health patients. It gives all patients, and they need to look at those who are open to our services or have been discharged. But definitely a good challenge, and I will have a look at it. Thank you.
Thanks, Di. Tim.
Thanks, Kevin. First of all, thanks, Girish, for a good and, as ever, sobering report. one comment and one question, really. I looked at the figures provided in the report, the graphs, etc., in a slightly new, with a new pair of eyes following our use of data development session that we had the other day. So anyway, thank you for that. I guess my question goes back on the benchmarking, and maybe I don't quite understand, categorization and where the data comes from, but that's not a conversation for here. I guess my question is around if we can't do that quantitative benchmarking, are we getting the most out of what I would call the qualitative aspects of discussions with other trusts in terms of particularly around the learning pieces?
Yeah, can I? I guess the chair is happy for me to answer this. I think there are two things.
I
don't
definitely am, Girish. Yes.
Yeah,
sorry.
thank you. So we don't go to individual trusts to talk about what is their qualitative assessments and learning, but what we do have is at the regional level, we have a regular update in terms of those cases which are considered of regional and national interest, and those are investigated deeply sometimes by the regional team or the national team, and whatever learning happens, that is communicated to each of the organizations. So we definitely have that. And then is the NHS also produces the regular updates with regard to some of the national learning, which are called as complex case reviews. So we do get information about that, which is then circulated to our clinicians. So this is what happens at the regional and national level in terms of learning.
Thanks, Girish. That's very helpful. Thank you.
Thank you.
Thanks, Tim. Eve.
Thank you. Eve Baird, Chief Operating Officer. 2 points for me. One is very small, but very important given that these are public-facing documents. So the chart on the top of page 4 talks about deaths in adult inpatients. It's actually adult inpatients in urgent care. So it's it may well be people that have had contact with our crisis services or our mental health liaison services. It's not people who have necessarily been an inpatient. So I just wanted to make that clear about that chart. And a thought from me looking at this, obviously this is only my second board, I'm new to seeing these papers. I wonder when we're thinking about being able to look for themes and really monitor whether we've got anything happening across our populations that we need to be worrying about. I wonder whether we could perhaps do some work with our data teams and our quality and safety teams around how we break down the data, because I think we do it by divisions because that's how we organise our services, but actually what that doesn't show us is if we've got any specific themes with particular cohorts. So if we were able to do that breakdown by service lines, what we would be able to see, for example, is have we had more children and young people where there's been deaths related with people who've had contact with our children and young people's services? Have we had more veterans? Have we had, whereas at the moment they both sit within specialist services division, and equally it would allow us to split out some of those nuances around somebody who might have rung a crisis line versus somebody who has been resident on one of our wards, and that's quite different learning for us from there. So I wonder, Girish, whether you'd be happy for me to link in with you and the quality and safety and data team and look at whether we could perhaps split out some of those nuances as we move forward with this work.
Yeah, thank you. I think that's a very useful suggestion, Eve. Happy to have the conversation. So a couple of things. One is with regards to thematic reviews, it's very, very time consuming. We need to agree that. And the second thing is we have done a couple of thematic reviews, particularly with regard to dual diagnosis and also with the suicides, which have happened in the last 5 years. So particularly with the latter one, it included, all the deaths, irrespective of the divisions, which was a useful learning. obviously, with regard to the earlier one on dual diagnosis, I don't think there were any patients other than those who were in the adult age group between 18 to 65. So some of them had inpatient setting as well. But yes, yeah, happy to have the conversation. Thank you.
Thank you, Girish. Thank you, Eve. I think that's a really helpful suggestion. What I'm going to propose is that Quality Committee takes a view on how best to report these data, so that we've got a balance between best use of resources, as it were, and not turning it into something that is unmanageable, and a product that enables us to draw the right conclusions, and answer some of the questions that you've suggested, Eve. So I wonder if the way to address that is for you and Girish to have that conversation, and then for Quality Committee to take a view on whatever comes out of it. Thank you. Amy.
Yeah, thank you. Amy Beaton, Chief People Officer. So Girish, for me, and every time we receive this report, it's really comprehensive in explaining the rigorous processes and the governance around that. So I think that's really clear and easy for a person that's not clinical to really understand how it's done. So that's really brilliant. For me, and please tell me if it's not appropriate for this report, but for me, I think I've said previously, I can't get from it what the learning is or the themes of the actual learning and therefore improvement. So there's a lot in the report on how we manage learning and improvements through subcommittees and how we share learning, but not what actually the learning is, and therefore what we're doing about it. And I know for confidentiality purposes, how we do that, but I didn't know if there's a way that we can theme that and then provide assurance on the actions we're taking against that learning. Thank you, Girish.
Thank you, Amy. Thanks for raising that. I think some of you may remember that when we initially brought the report, there was an appendix with regard to the learning, and it was, and it was categorized based on the different, incidences happened. So, so it was a very long document. So that is why, the board wanted, as long as the process is right, that is enough for the learning. And one of the other challenge which was also put forward by the board was, yes, you have mentioned about so many things as a learning, but what is the impact of the learning, which was again, we had so many discussions about how we show the impact, but we need to recognize that when we are talking about the impact, one particular incident and one particular action may not necessarily bring the impact. And we are talking about deaths where the numbers are so small, and to have that one-to-one relationship is also extremely difficult. So my understanding in the previous meetings was, having that, providing that assurance framework. But if the board wants me to come back with some of the key learning, happy to do so. Thank you.
So I think, Girish, that going back to Eve's point, if as a board we want to review the way in which the report is presented, and in particular to bring out the sort of themes that Eve has suggested, there may well be headline learning that comes out of those. What I'm reluctant to do is to build even more of an industry around this if we're not clear that it's adding value. So which is why I'm quite keen that if we go away and do a little bit of work to maybe retool the way in which the report is presented, and then ask Quality Committee to take a view on whether or not that is providing an additional level of assurance that is worth having. And then we can build on the basis of that. So a last comment from Sharon.
Thank you, Chair. Sharon Harvey, Chief Nursing Officer. My comment was in relation to LEADER, and I just wondered, so LEADER's obviously around learning from lives and deaths of people with a learning disability or autistic people, and the purpose of being around, we know too many people with a learning disability or autistic people die too early, either from physical health problems, mental health problems, not from their learning disability or autism. But I wondered whether we think we've captured the learning enough, Girish, or whether you think there's more for you and I to do, because I know that we, the paper's really clear that we reference the feedback from the regional meetings within the mortality surveillance group, but there's something for me about how we're incorporating that learning in our health inequalities work, in our physical healthcare work streams, and I just wonder whether you think we've got that, or whether you think there's more that we need to do.
Yeah, thank you, Sharon. So at this point of time, LPFT clinicians are involved in the LEADER process, which is led by ICB, and the learning from there, uses the same process in terms of coming to mortality surveillance committee, and then through the quality leads, it goes to each of the divisions and then to the clinicians. And the ICB also produces a detailed report for each of the deaths in a very comprehensive manner, which again we circulate to all the clinicians. But happy to have a conversation with you to see whether we can do more about that. I think one of the requests from the ICB has always been to have more reviewers from LPFT, and this is something which we have not been able to release as much as they would like for us to release, but we are looking into that. Thank you.
Yeah, I think we follow the processes, and absolutely we've got gaps in terms of as a system having enough leader reviewers. I just think because the leader review isn't just about that point at the person died, it's about the care significantly before and different care points. I'm just wondering for that. And I also wonder whether we just want to clarify the point, and for the minutes around, it's not that people with a learning disability and autism die of that learning disability and autism, it's around the preventing deaths too soon of people with a learning disability and autistic people, if that's okay for the minutes, Chair.
It absolutely is, Sharon. Thank you. Thank you very much, Girish. Got one more item with you, and then I'm going to suggest we take a short break. So you've got the next item 3.4, which is the update from the Guardian of Safe Working.
Thank you, Chair. I just saw a chat from Sarah Whiteman. I just wanted to mention that, any deaths which happen who is under our care, we link up with the medical examiner's office before we complete the forms onto the system. And if they have any feedback, they generally come back to us within a few days, which is generally a good response. Yeah, so the next paper is on Guardian of Safe Working, and this is authored by our Guardian of Safeguarding Leads. So this is for the board to assure that LPFT is compliant with the terms and conditions for the junior doctor's contract. Some of you may be aware that the junior doctor's title is now changed to resident doctors as a part of the negotiations between the BMA and NHSE. So for people who are not aware of the junior doctors training, so we have 4 different categories of the resident doctors. So one is the foundation year, which is a 2-year training after doing 5 years of medicine. And then after that, they take up core training, which is for 3 years in psychiatry. And then after that, there is 3 years training, which is called as specialist trainee. And then when there are gaps, we have some fixed term appointments, such as the MTIs or the medical training initiatives. The number of trainees which are posted varies every 6 months to 4 months. It is based on the rotation period and also how many allocations each of the organization get from the deanery. And once they are posted, we do have some vacancies because some of the doctors do leave during their training program, or for personal reasons they are off from work, such as for sickness or maternity leave. I mean, the report clearly shows the table where how many doctors we have in each of these categories, which are more or less within the usual range. And if these doctors are vacant, then we generally appoint fixed-term doctors to ease the pressure. One issue where we always have is with regard to on-call covers, but we have a robust system in terms of covering the on-call rota gaps, which is generally within our existing workforce, and we hardly have to use any agency locums in the organization. So on an average, at any given point, depending on the number of doctors posted to our organization, we have 10 to 20% of vacancy among the on-call rota. There is also a national requirement that if we are not complying with the terms and conditions, where we are asking some of the doctors to work beyond their working time directives, then they escalate to Guardian of Safe Working. And you can see on a report that we had only 4 in the last quarter, which is again within the normal range, and they are resolved at the very local level. And the Guardian of Safe Working also has the right to fine the organization if we haven't amicably resolved in terms of these terms and conditions. So in a nutshell, we are, as always, compliant with the requirements. And if board is happy to note the content and approve. Thank you.
Thank you, Girish. I don't see any comments or questions from anybody, so I think we can assume that the board is content to know. And thank you very much, Girish, for a report which is, as ever, comprehensive and informative. Thank you very much. I'm going to suggest we take a 10-minute break. It's now 3 minutes past 11, so let's reconvene at a 1:15. Thank you.
Thanks.
Okay, thank you, everybody. It's now past, so let's restart. Next item is item 4.1, which is the highlight and exception report from the People Committee. So, Tim.
Thanks, Chair. So Tim Harry, non-exec and Chair of the People Committee. We've got the exception report from the last meeting, as well as also the annual report. So I'll cover both briefly, if that's okay, Kevin.
Absolutely, yeah.
Okay, so 3 things just to pull out of the exception report. One is we obviously gain assurance from progress against the outstanding People Strategic Delivery Plan, and we have good assurance around that. But we also recognise and have fed back about development and maturity of the reporting in, which is all part of the sort of natural process and kind of where we are. But we do get good assurance around that. The other couple of things I really wanted to pull up on was around, it kind of relates, I suppose, to the change in, well, no, the breadth of scope of the People Committee. And one is that we've had a particular focus around recruitment, retention, and issues around equality, diversity, and inclusion, and bullying and harassment. And that's probably what you've heard mostly around in previous exception reports. But the scope obviously does include training and development. And this last meeting, we had a very comprehensive report, which gave us assurance around the multiple elements in this sort of area. There's further work to do around the trading needs analysis, but otherwise we were gaining good assurance across that. One of the other elements which is new to the committee in its scope is around health and safety. And over several meetings, we've received reports, plans, etc. And I think the committee is getting more to grips with this, as well as receiving more developed plans, etc. But it's an area that obviously we'll keep an eye on as we move forward. So that was the exceptions report. In terms of the annual report, I think it's pretty self-explanatory. Just to give a little bit of narrative and context around it, what it does do is reflect the transition under the new governance arrangement. So, for instance, whereas previously we looked at the People Work Plan, we now look at the Strategic People Delivery Plan. What we have gained assurance around is from Amy that all the areas that were previously in the People Work Plan, where we were looking for further assurance, has been carried over into the Strategic People Delivery Plan. So we're confident that it covers all the right areas. The story around the challenges around recruitment and retention. So following all the great work that Amy and the team did in terms of the initiatives and approaches to recruitment, we now have a new challenge in terms of recruitment versus affordability, but also the emphasis is much more on the sort of hotspots and individual executive directorate areas and the implementation of those new initiatives. There's obviously the ongoing story around the challenges in the belonging area, around inclusivity, etc., bullying and harassment. And these are reflected in there as longer term challenges. But I think at times we found over the year that progress was somewhat frustrating. So we have escalated some of those items to the board as we move through to look at how we can achieve our ambition. And you've obviously got to paper on the gender pay gap, which is probably reflective of that sort of general area. So I think that was it, Kevin. Thank you.
Thanks very much, Tim. I think, as a board, we can take a high level of assurance from that the People Committee is focusing on the key areas that the board would want them to. I think we need to have. Sorry, I'll rephrase that. The board needs to approve your annual report for onward kind of transmission to the Council of Governors. So in the absence of any questions on the content of your exception report, can I ask colleagues to indicate whether or not they are happy to approve the annual report? Sorry, struggling to get words out in the right order. Excellent. Thank you very much. Thank you very much, Tim. We'll move on then to the gender pay gap report. Amy.
Yes, thank you, Kevin. So Amy Beaton, Chief People Officer. Just to be clear, we are asking today for board to approve this report for uploading on the Government Equalities Office website as per our legal and statutory obligations. So, and just to highlight as well, as Tim has already alluded to, this did have thorough discussion in the People Committee and before that in People Governance Group as well. So I'm not going to highlight the actions that we've delivered or that we've suggested. There I feel quite comprehensive in the report. What I will highlight is how we're going to ensure they're delivered and they have an impact, which is what I will pull out. So as the report says, we have a gender pay gap, 17.5%. We've been reporting against this since 2017, and we've seen a 2% reduction in that time. And that is not the shift we've want to make. So we benchmark well when compared to Lincolnshire system partners, but not when compared to regional. And I think if I can just draw board's attention to the 3 bullet points on page 2 as to why we've not seen what our reflections are and why we've not seen that shift that's required. And if I particularly just hone in on the 2nd bullet point, up until now, we've analysed gender pay gap data once a year as part of this reporting. And therefore, it's been difficult to see the impact our interventions have been had. And I'll take accountability as well that the action plans have really sat centralised with my team. And as part of our aspirations on embedding equality, diversity and inclusion into our governance structure, we've worked really closely with our business intelligence colleagues to build an EDI dashboard that now enables us to see gender pay gap data more frequently than once a year, and it will be embedded into both the performance and the people governance routes. So we're hoping that therefore we will be able to drive ownership at that local level as well as organisational level intervention. So very similar to how we have done with the National Staff Survey. So conversations are occurring more frequently all the way through the governance structure in the organisation and being owned by multiple teams. And also what I would say is the paper does articulate that from a band 8A and above is where we start to see our data not reflecting the representation in our organisation. So generally up until that point, we are 80-20 women to male ratio. We've got a number of interventions identified in the report. A huge thanks to our women's network who actually have done work in the last year on this. Some of that is going to around cultural change and will take longer to show in the data, but they've also recognised that we've not seen the shift and they've aligned their priorities to the gender pay gap data, which we're really thankful for. Other areas highlighted because above band A includes us as a board as well. And so we do have a board development session in December, where we are discussing our ambitions in our equality, diversity and inclusion space as a board ourselves and for the organisation, so that we can see improvement. And then finally, what I would say is I'd welcome board's feedback on the report. It has really changed from last year. So we've taken into account all the feedback that was given, but noting that we've got new board members. So if there's any improvements, that would be good. We can't move to SPC charts yet because I need 15 points, and this has only been going since 2017, the reporting. So previous comments around the data, that's limited us. So thank you, Kevin. I'll stop there.
Thanks, Amy. My view is that the format presentation of the report is excellent and an improvement on previous years. I think the key point for me in the covering paper is at the top of page 3 with the brief summary of actions, which seem to me to be the right sorts of actions that we need to pursue, given what you say about, rightly I think, in the report and in your comments about the kind of structural underpinnings for some of the disparity that we see in the data in the report. So I would invite colleagues to focus then on format presentation of the report, whether or not we're happy for it to be submitted in the way that Amy's described, and any observations on the summary of the actions that Amy has highlighted in the paper. So, Sharon.
Thank you, Chair. Sharon Harvey, Chief Nursing Officer. I really like the report and I can see the improvements that have been made, Amy, so thank you. I really welcome the EDI dashboard and the regular line of sight on that, especially as the joint exec sponsor for the Women's Network with yourself. Thank you for your tenacity on it, Amy, because I know it's not been easy to get to this point, and I think if you hadn't been so tenacious, we wouldn't be, and to the digital and data team, of course, as well. I think the challenge to us in your recommendations is clear and is one on us taking accountability and taking accountability loudly as a board, and I commit to doing that. So thank you. I really welcome the report and support it.
Thanks you, Sharon.
Thanks, Sharon. Chris.
Thank you, Kevin, and thank you, Amy, for the report, which I do think is a really good report, and the presentation is excellent, and I support it being wherever it has to go. But the issue is really the content of the report, and at risk of stating the obvious, well, it's not a risk because I'm about to, is in an organisation where 80% of your workforce are women. And we've still got a gender pay gap of 17.5%. It clearly demonstrates the entrenched structural challenges that we as an organisation need to grapple with, but broader broader society needs to deal with as well. And so I just want to I really support the approach that you're setting out, and but to Sharon's point, this is fundamentally about accountability and all of us taking ownership for it. And there's some really complicated issues around employment, flexible employment, all those kind of things, but also about how we progress people in organizations like this and what we need to do to support that. So we just have to I was surprised when I first saw this 2 years ago that the numbers were as they are, 2% better, but that's not good enough, and we just got to all get behind this. So thank you for highlighting it, and as Sharon said, for your tenacity on this. Thank you.
Thanks, Chris. Di.
Di Bailey, non-exec. Thanks, Amy. Really comprehensive report, absolutely support. I just wanted to come back on what I thought I heard you say, which was that there are some cross-cutting performance issues as well as kind of workforce issues in terms of the plan going forward to address this. And that just made me think about whether or not, given the more frequent reporting, whether we should have something on this at Performance Committee under the best use of resources measure. We only have one measure in the IPR at the moment that we're looking at Performance Committee in terms of best use of resources. But it just made me wonder in future whether we perhaps ought to have something around this there, particularly as that committee meets bi-monthly, so could augment the kind of people focus that would go on in People Committee. So if that's helpful, happy to discuss further if need be.
Thanks, Di. So my reference to that in the paper was historically we've not reported EDI data into our divisional delivery oversight groups, into medical management team and into corporate management team, and we're going to change that going forward. Now we've developed an EDI dashboard that enables us to do that. Therefore, the workforce paper that goes into performance delivery oversight group will now contain these metrics, which historically it's only dealt with vacancy, sickness, turnover, appraisal. So we're getting EDI metrics now into that performance, and that will then feed up into Performance Committee as well. So that's been an aspiration and it's now coming to fruition.
Well, thanks, Amy. And I can see that Mark's already responded saying it'll be on the balance scorecard. So we're already there. Okay, that's great. Thank you.
Thanks, Di. Ian.
Thanks, Kevin. Yeah, a really good report, I thought, Amy, and I fully agree with the proposed way forward. I just wondered, I cast my mind back to your recent success of on the recruitment front and the numbers there. And I know that you know they are proportionately small to the whole population of the organisation. Nevertheless, a significant amount of recruitment for us. Have those sort of cases helped turn the dial in any way, or is that something that we can't quite see yet?
Probably can't quite see yet, but I will have a look into that. You'll see in the improvement plan for this year, we're talking about a male recruitment drive. So some of that positive action that we are taking, because as you will have seen, it talked about males in entry roles. So because obviously our workforce representation of that 80-20 is not the representation in our community. So we're trying in terms of our interventions, but I think that's what I alluded to for board development session in, you know, what's our ambition in this space, and therefore what positive action do we want to put in place, particularly around those senior roles. So I'll have a look, Ian, and bring it back into People Committee, because I know you're also on People Committee.
Thanks, Ian. Sarah.
Yeah, thank you. Really, really great report, Amy, albeit one that, you know, we don't want to be reporting on that significant gap. I'm just looking at the comparison with other trusts in the Midlands region. I think it's page 10 in the report, and the range is massive, isn't it? And I'm just noting that some of those that are performing better in terms of less of a gap are in our East Midlands Alliance, and whether it's one to take to the People Directors Forum for some learning to see if there might be anything there.
Thank you. So we've already done that, actually. We've reached out to all the best performing, and that's why we referenced that our action plan for this next year does include some of their learning. Some of it's interesting and their starting points were different. So, for example, Notts Healthcare, all of their executive team is female other than their chief exec. And so that plays into a lot, but their starting point was much lower than ours. But there has been some shared learning in terms of what we can do in terms of encouraging females to apply into those senior roles that we are taking on board and does show in our action plan. So absolutely have gone out to those that are performing well. And we did discuss that in People Committee. Sorry, I should have highlighted that.
Thank you. Thank you.
Thanks, Sarah. So, Amy, I think 2 or 3 things. The first is it's really important that board reaffirm its commitment to the kind of underlying agenda here, and I think you've heard really clearly that is the case. The second is that the board confirm that the sorts of actions that you've got in place that address the kind of structural issues that have been alluded to, the board support those actions, and I think you've heard that too. Thirdly, that the format of the report is spot on, really easy to understand, helps point us at what the important issues are. This list is getting longer. The fourth point is this is something that the board through People Committee is going to stay engaged with over the coming period, and it's reflecting the priority that we give it. So thank you for all of that. I need formally to ask colleagues to approve the report for upload to wherever it needs to be uploaded to. Thank you very much for that. So thanks Amy, and thanks for presenting that in a really helpful way. We'll move on then to item 5.1, which is the highlight and exception report from the Best Use of Resources Committee and the committee annual report. Chris.
Thank you, Kevin. Just in terms of the highlight and exception report, the committees actually met twice in the last period. We had an extraordinary meeting as well. I won't. The first meeting focused on 4 areas. I won't spend too much time on the first area, which was the BAF, because Karen referred to that earlier around the way that we're approaching the risks associated with best use of resources. We spent a considerable amount of time on the financial plan, and that led to an extraordinary meeting subsequent to the diaried meeting. There's obviously a lot of pressure both in the system and also within the trust to ensure that we get as close to delivering the plan as possible. And the extraordinary meeting, which we held in late October, came back with action from the exec team, which is a really clear commitment to get ourselves as close to delivering our plan as possible. And we commend our colleagues for all the hard work that's gone into that. Back to the original committee, we also received quite a sobering report from our new Director of Estates, who had undertaken a review of our compliance across the range of our estate activity with various regulatory requirements, and highlighted some areas which needed some urgent attention and gave us confidence that urgent attention was being applied. And we subsequently asked to receive quarterly update reports from Mark Swain in relation to how we're progressing in terms of our estate and regulatory compliance. And then finally, we received a self-assessment around our emergency preparedness, resilience and response approach. And we scored ourselves 89%. but we, I think, still at the time of speaking, are waiting for NHS England's assessment of our assessment, and which might differ. But we as far as I know, we haven't had that yet. So those were the highlights in relation to the committee meeting. If I turn to the annual report, I just want to say a couple of things. I've now been chairing the Sustainability Committee, now the Best Use of Resources Committee, for 2 years. And I'd like to thank my colleagues on that committee, both the non-execs and the execs, for creating an environment which I think allows us to be challenging, and also there's a real sense of transparency and openness to the issues that we're looking at, and it makes the committee a really good place to raise issues and to test and challenge our practice in relation to the use of resources across the trust. So we had a full year of activity, scrutinised much of the trust's approach to managing our resources, and we've received business case reviews, deep dive reviews, oversight of a financial plan. We've looked at operational controls and indeed strategic planning. And so I think the report captures the confidence of the committee in hopefully overseeing and delivering on its responsibilities. We commend it to the board and our Council of Governors.
Thanks, Chris. But both reports really helpful and comprehensive. I need to invite colleagues, please, to approve the annual report for onward transmission to the Council of Governors. As ever, Chris, really grateful for the work that you and the committee do in terms of making sure that we are getting as close to our plan as possible, and that we continue to stay focused on delivering really good value for money. So thank you for that. We'll move on then, if we may, to item 5.2, which is the highlight report from the Performance Committee, and I think for approval the committee's terms of reference, and then we might kind of segue seamlessly into the IPR. So, Di.
Thanks, Kevin. I'm taking the highlights and exceptions report as read. I just want to highlight 3 things in just a slight more detail. So the first is in relation to the discussion that we had at Performance Committee around out of area placements. And the reason that this was important was because just the previous day, we'd had the system level performance and delivery committee where we'd been asked to present the situation around our out of area placements. And so we received endorsement both at system level and then at our own performance committee for the plan that had been pulled together by Eve, Baird and colleagues in terms of how we would reduce the number of out of area placements going forward. Not without challenge, the plan, but very much evidence informed. And for that reason, we've asked for a deep dive to come to the January LPFT Performance Committee to make sure that things continue to be on track. But it was good to have the timing of the system level committee so that we were able to provide that level of assurance there as well as internally. I just wanted to say something about staff sickness from the point of view that Performance Committee hasn't been meeting as long as the other committees, which is one of the reasons why there isn't an annual report here. But I think the way that we talked about staff sickness was a real example of where the Performance Committee is starting to pick up now those cross-cutting issues and work as it should. So we recognise that overall our performance in terms of staff sickness was falling, but that we had some real hotspots where there was a corresponding level of vacancies and staff sickness occurring in services at around the same time. What the Performance Committee took assurance about was how we are monitoring that staff sickness and managing it. What People Committee are doing is to get behind some of that and look at the drivers and how we can support staff who are sick going forward. And so we had a really aligned conversation, I think, about the work of the two committees in terms of coming together to understand that issue in more detail and deal with it appropriately. And then finally, just in relation to the integrated performance report, so you're right, Kevin, we will segue into that. We had a really thorough conversation about how some of the targets that are set are more meaningful to us than others, and in particular our performance against our regional comparators and more nationally. And we really remain committed to looking at measures that are meaningful to us, as well as those measures that we are mandated to look at. One of the things that came out of the system level performance committee was with the new government administration that we are being persuaded to look again at the constitutional standards for the NHS. And Eve very kindly, after the performance committee, had a quick look to make sure that we had cross-reference to some of those in our measures in the IPR, and so we are assured that we've got coverage in most areas. So I'll stop there.
Excellent, thank you, Di. Thank you for the work that the committee is doing. Before I pass over to Mark on the IPR, I think I need to ask colleagues to formally approve performance committees terms of reference, so people are able to indicate that in chat. That would be really helpful. Thank you very much, and I agree with you, Di. The what's the word I'm trying to find? The effect of the performance committee is starting to be felt, so that's really positive. So I'll hand over, if I may, to Mark Platts for the integrated performance report. May come back to you, Di, to link some of the things together, but Mark.
Excellent, thanks, Chair. So good morning, everyone. I'm Mark Platts. I'm the Trust Chief Finance Officer, and I'm here today to present the integrated performance reports for November. So picking up on some of the key headlines, it's important that we do make the best use of our resources, and we are referencing in the report around our estates and how we can make sure that we really bring our estate to life and make sure that it's not only safe but therapeutic and a pleasant building for our staff and patients to utilise as part of care delivery. What's also important is that we don't overuse it, and there are a couple of pressure areas, particularly within our older people service at the minute, where we are having to admit an increased number of patients over recent months, which is adding pressure onto an already stretched service. So the teams there are working really closely to manage that and make sure that leave beds are used appropriately and pulled forward. What I can say is, personally, I was down there last Thursday night visiting the teams, and actually the interdepartmental working was really good to see, and it was great how the teams were coming together to support patients across the two wards. So important to get the best use of our resources, but we can't overuse them, and I think that's a really important point to note from a quality perspective. In terms of things that are going really well, so we've touched on successful recruitment. So we've almost halved our vacancy factor from 12 months ago. We're just under 12% now, 11.6, and we were over 20 a year ago. So fantastic pieces of work But as Di mentioned around staff sickness, it's really important that we focus that recruitment in the areas where the key vacancies are, and we can manage the teams to balance that sickness and start to stabilise our services. So I think that that's really important. But a number of different work streams are underway, both operationally and HR led, around helping us to build that stability, whether that be around improvement in rostering or sickness support and sickness management, which is really important. And another key area that's going really well is we're starting to really bring innovation to life. So the report notes a couple of exciting projects within our eating disorder service. So look forward to seeing how they progress moving forward. And the final note within that section does make reference to our children's mental health services. And whilst we have noted the improvement in the waits there down to 40 weeks with no children waiting over the year for that service, it's important. It's even more important to note, and this did come up in performance committee as well. So thank you, colleagues, for the discussion, that's still not good enough. And we know that. So the teams are really working hard to bring that down to as close to zero as we can get from a waiting perspective. So really, really important, especially given today's board story that we held earlier on. In terms of current challenges, Di's picked up on this through the performance committee, and there is that deep dive around the out of area pressures that we do see. But bed occupancy across all of our services is really high at the minute. So we've actually averaged nearly 96%, 95.9% over the last 7 months, with, as I mentioned earlier on, some of our wards actually exceeding that 100%. So really important that we can manage that demand and bring our patients back home and do as much as we can on that. The task group is working really well. We are seeing those numbers come down with live data, but work's on way, and we need to keep an update on that. So that deep dive will really help to provide that assurance around what's going on. In terms of the increased demand on our service, we need, as demand increases, so does the pressure on our staff. And I think that's really important to note. And some of the areas that we're looking at around supporting with sickness and rostering will really help to stabilise that service and kind of manage teams as best we can, really. As Chris Wright has also mentioned, we are facing some financial challenges as an organisation, as an NHS, as individuals. So it's really important that we balance this out and make sure that we can do what we can around making sure that our financial resources are put to best use. In terms of some of the key access metrics that we're talking about, the report makes note of the having sight and increased knowledge around the experimental national 4-week waiting time standard. So this is helping us to understand how nationally things want to be reported and how we can support our patients to wait as little time as possible. Where they are waiting, wait well, and we can kind of pull through that, really. And as Di's mentioned as well, we really need to focus on the meaningless of some of these targets. So where do we want to be as an organisation, and not always focus our attention on the nationally mandated targets. So I think that's really, really important. Some great work going on within our crisis services. Obviously, fast access to those services is vital, and there's a good transformation group looking at evolving on that. So there's a bit of text within that, really. From an experience viewpoint, we are continuing to review how we collect our patient feedback. We need to make it as quick to give the feedback and even quicker to understand and act on that feedback, and how we can do that. Some really good digital technologies out there that we can look at. As individuals, we can't go into a supermarket anymore without seeing that quick feedback with the smiley face buttons. We need to look at different ways of getting our patient feedback to make it as simple as we can. So we have got some metrics that we're working on, and they will be live within the report, certainly within Q1 next financial year. From an experience viewpoint, I've mentioned getting the best use out of our estate and our wards. We really need to continue to balance safe and therapeutic care delivery within our buildings. So our estates team, as Chris has already picked up, they continue to work on keeping our buildings safe. So we do have plans and preventative maintenance schedules that are in place now, and we're really seeing an improvement in our grip and control around that. And that's even being validated by external visits that I'm sure we'll come on later on. But the Fire and Rescue Service have been to some of our wards recently and did give our kind of satisfactory level of appreciation around the processes that we're doing around that. So that's positive. And we're taking all of that learning that we're looking at, and we're going to look at implementing all of that within our new build over in Boston, which is going to give us 19 bedded ward and hopefully provide the best safe and therapeutic environment that we have within our trust. So really positive work on that scheme. That's the building on that is going really well and will be online by 2026. We continue to work alongside our patients, staff and carers to deliver how we deliver our care. So ongoing work around our fundamental standards of care, that's going to help shape the service delivery today and in the future. And other areas such as our complaints policy, we've revised that and that's now live as well. So again, we can hear the feedback quicker and we can act on it even faster. So really, really important. From an outcomes perspective, our digital and data services team, I touched on this last time we presented this, they've actually collated the over 50 metrics that are out there within our services when it comes to looking at outcome metrics. We're looking at how we can theme that and aggregate that up into this integrated performance report. So just looking forward to see what comes out of that one. Finally, just going to look at best use of resources, and I've mentioned we are facing those financial challenges as an NHS and as an organisation, but it's really important to note we're doing all we can to manage that. And one area of success at the minute is we are seeing our agency reducing, which is really positive to see, because not only does that mean that we're saving money because we're not paying the agency premiums, but more importantly, that means we're not needing that shift by shift cover that we tend to use agency for, which is allowing our teams to be more stable and provide the best care we can. So some really positive work around that in a very stretched and challenged financial environment. My closing points are just around the integrated performance report itself, and Di's mentioned that we are continuing to evolve and move that forward. We as a board and a group of senior leadership teams, we had a great session with NHS England who came to us last week, talking around how we can make our data count and how we can improve that. So we'll further enhance that moving forward. And like I say, the report does make further commitment around the delivery of some of the metrics that we're not currently reporting on, but they will be coming to an IPR near you soon. So happy to take any questions.
Thanks, Mark. My first question goes back to the Performance Committee report, Mark, and there's a commitment in that to have a first cut of a balanced scorecard going to Performance Committee in January. If I was to put you on the spot, when do you think we might be in a position to have a refined version, having gone through Performance Committee, coming to board for us to engage with?
Yeah, good question. Thanks, Kevin. So we met as a group of leaders for the quadrants of the proposed balanced scorecard last week. We already have 5 or 6 metrics that we're looking at for each of those. So I'm happy that we'll be able to get it through Performance Committee. We did talk at Performance Committee about meeting as a bit of an extraordinary meeting before the next formal meeting, so we can bring it into the process quicker. So I'm confident behind the team of what we're doing with that.
Okay, thanks, Mark. Di?
Yeah, just to come back on that, Kevin. So as Mark says, I think we're expecting to see something in January. I guess the question for me is what further input might board want with this in terms of, would it be helpful, for example, to spend a bit of time at board development to have a further look at it before we bring it through the formal governance process? So, I think as chair of Performance Committee, I'm happy either way. But I think having seen the usefulness of those board development sessions in other areas, I think this might be one where it would be a good use of time. But over to you, really, to see.
I think that's an excellent suggestion. We can add that to the list of several things that we've got for future board development sessions. I think in particular, as a in a board development context, we might want to think about how we use how we get the best use out of the balance scorecard alongside the IPR, so that we haven't got two separate kind of lines of reporting and we don't know which to look at. And so we need to work through what it is as a board we need to know, as opposed to what it is that the performance committee, needs to engage with, and how we best balance that. So I think that's a useful piece of work to do at board development.
I think that absolutely follows on from our conversation, Kevin. Thank you.
Good, thanks very much. Thank you, Mark. I don't see any other questions for you, and that, I think, is probably testament to both your presentation of the IPR, the fact that it is, if I think back now, a significantly more comprehensible read than it was, even 18 months ago. So, really grateful for that. Thank you. We'll move on then to item 7.1, which is the highlight and exception report from the Audit and Risk Committee. Ian.
Yeah, thanks, Chair. Also on the back of that is the annual report. So if it's okay, Chair, I'll rattle through the two of them.
Of course, please do.
So that helps. They're both fairly short reports, so I won't spend too much time on them. I think they're both pretty straightforward. In terms of the highlights and exception report, it follows a recent meeting only about 2-3 weeks ago for the audit committee, so it's pretty current, as it were, and covered a range of issues that are effectively part of our or the committee's annual plan of work. Just wanted to highlight probably 3 things in there. One was internal audit, and we've board members will know that we've more recently had a sort of difficulty with internal audit, and then, in my mind anyway, sort of made really good progress against those particular challenges. The last meeting, that didn't feel quite the same, and there is an issue regarding our responsiveness to internal audit reports, and I'm expecting a report shortly to see how that is moving. So I don't think that's something that will become problematic, but I felt I needed to make board aware. The other couple of points I want to mention, one has had a few mentions previously this morning, and that's the BAF, and that is, as I think people have said earlier on, is developing well. So that was on our agenda last time and will, of course, remain so. And then the final point I wanted to make from the previous or the recent meeting was that the committee supported a proposal to set up a policies and protocol review group. And I think this is really important. We were talking before about risks and so on, and I think having robust policies and procedures are absolutely key to what we're about. So that particular group will report into the audit committee, and hopefully we'll all see the benefit of the increased effectiveness there. So broadly from that session, positive outcomes, and we hope to continue things in our next meeting. In terms of the annual report, obviously this is a look backwards onto 23-24, and I won't go through it in detail, but it covers off sort of the role of the committee in terms of membership and regular attendees. And I just wanted to say that as committee chair, I've had great support from really good contributions from exec and non-exec colleagues. And also we also have people who are external to our organisation come along periodically, and again good support there. In terms of some of the issues covered, as you'd expect, lots of stuff around internal controls, the BAF, the governance arrangements and so on, and that will always be a key part of our agenda going forward. Just wanted to mention a couple of things that are specific to 23-24, if I may, and that is we received a head of internal audit opinion that provided us with limited assurance We know that we want to see that improve, and we'll be looking to try and support that in the coming months as we get towards the end of 24-25. But also I wanted to mention as well the external auditor's assessment on our annual accounts, which gave us a clean bill of health, gave us some really positive messages in terms of those accounts, which augurs well for the future. So I'll draw the line there, if that's okay, Chair, and take any questions.
Yeah, grateful. Thank you, Ian. Thank you for the comprehensive report and for continuing to be focused on assurance and so on. So I'm really grateful for that. Thank you. Can I ask colleagues please to indicate in chat whether or not they are content to sign off the annual report for it to be transmitted to the Council of Governors? That's excellent. Thank you. I don't see any questions on either the highlight report or the annual report. So thank you very much, Ian. We'll move on then to item 7.2, Amy, which is the health and safety and fire annual reports.
Thank you, Kevin. I'll flip the order if that's okay, and we'll start with the overarching health and safety report. So again, just to confirm, this is for approval for publication on our internal website as one way of showing that we've met our statutory responsibilities. So I'm also the exec lead for health and safety now. That's a fairly new allocation to me. So if I can't answer some of the questions today, I will come back. But as part of taking on that new role, had looked into our duties, which are really clear. What I would say is less clear is there's little guidance on how to demonstrate we comply. So I'm informed by the Director of Estates and Sustainability, NHSE have recognised that. They will provide more guidance. And the content of this report is in line with other organisations when we've benchmarked in terms of the areas we're scrutinising to demonstrate compliance. This has been to Health and Safety Committee and People Committee twice. And the reason for that is this reporting period is 23-24, and our now Director of Estates and Sustainability came in approximately 6 weeks after the end of that reporting period, and they conducted their own health and safety assessment. So it was asked from People Committee that it went back to Health and Safety Committee, and the Health and Safety Work Plan that reflects the improvement areas identified in the annual report also included the director's assessment as well. So I acknowledge actually that the detail of the health and safety work plan's not included. If board would like that circulating, I can ensure that happens. The report details some key areas for improvement, such as stress management, moving and handling, and incident and near miss reporting, all of which are contained in the work plan. But it was identified in People Committee that there was a theme around reporting and the need to improve the quality of the data through educating staff and providing clarity and expectations so that we can reduce the variation and leave less for interpretation, as alluded to in the report. And People Committee also did recommend multiple areas for improvement in the next report, which were noted, so such as the presentation of the data, so it's more context benchmarked and meaningful, because some figures were presented and it was difficult to understand whether how good or bad or what that indicated. So, but the committee were assured we were compliant with our health and safety duties, and then therefore recommended it to board for approval. Thank you, Kevin.
Thanks, Amy.
Oh, sorry, Kevin, I've missed the annual fire safety report.
Go on then. So go on.
Just to follow on from that quickly again, it is for approval for uploading onto our website. Director of Estates and Sustainability did exactly the same, did an assessment around fire safety, and therefore on page 2 of the report you'll see the assessment of areas that they feel need to be improved on, to provide great assurance or to improve the standards of fire safety management within the trust. So that's detailed in the assessment section. As the paper does detail, better utilisation of technology and external experts to advise, considering the context of the trust. So that's where he really sees some of those improvements coming through. It's been through Health and Safety Committee, it's been through People Committee, who were both satisfied with the recommending to board publication and supportive of the actions identified to improve. Thank you.
Excellent, thank you, Amy. And the headline is that both of these reports have been thoroughly scrutinised in committee before reaching here. So can I ask colleagues to indicate whether or not they are happy for both reports to be published? If you've got an issue with either of them, please let me know. Excellent. Thank you very much, Amy. And thank you for the detailed work that's gone on there on the scrutiny. We'll move on then to item 8.1. Karen, forthcoming board programme, anything that we need to note?
Nothing specific, Kevin, just to note the busy January in 2025, soon fast approaching, and the next round of board assurance committees. Other than that, nothing to flag specifically, Kevin.
Thank you, Karen. Item 9.1 then, investment appraisal framework for decision. Chris.
Yes, thank you. Yeah, so Chris Higgins, Chief Transformation Officer. So this paper has been through the Best Use Resources Committee and recommended for approval there, but it's basically making 2 changes to the investment appraisal framework. Firstly is introducing a new gateway process for new investment requests. Previously, teams could just put in business cases for investment and they'd be considered at various points throughout the year. What we're doing now is to make sure there's more strategic thinking behind investment decisions, that it will be the executive team that commission business case development. So ideas are put to the executive team and then we consider them in the context of the current operating context and the strategic direction of the trust, and then commission the business case to be developed afterwards, which basically has 2 benefits. It means that investment decisions are done in a more strategic way, and also means that we're not wasting unnecessary effort on the development business cases that might actually go nowhere. There is a discretionary element in there for the exec team to approve things up to 250,000 if there's a current pressing need, but we would always try to adopt the process of our established routes of the business case review team, senior leadership team, and then through to Best Use Resources Committee. So that's one change. It's just tightening up the gateway process. And the other is the introduction of a standardised bid, no bid process, basically an opportunity analysis process to make sure we've got consistency on new developments as they arise, that we've got a clear process for assessing those that's done in a consistent way and maps back to our strategic intention, our risk appetite as an organisation. Again, following through the business case review team group and our senior leadership team to make sure we've got a sound decision on those, and any decisions on bids that are of relevant values will obviously come through the committee structure into the board's attention. But it's other than that, it's staying the same apart from a couple of minor grammatical tweaks and name changes, so no other changes.
Thank you, Chris. They sound like eminently sensible changes to me. Sarah.
Yeah, absolutely approve the changes, and just makes sense, and I think will be a much more slick and responsive organisation and decision making because of it, and save a lot of capacity from people writing business cases that aren't going to end up going anywhere. So I just, in terms of the best use of resources, I think it absolutely does what it says on the tin. There was just one, I think, around our risk appetite, given that we've just approved the refreshed framework. I didn't know whether we might want to just put a hyperlink in, given we want to keep it live. And so there was just that one. And then there is a bit of a typo in one of the appendixes around, it says 1.25 million rather than 125,000. So it just sorry to be pedantic, but it's one that we do need to get right before it's uploaded. But brilliant piece
Absolutely.
of work. Thank you. Thank
Make
you.
sure that's corrected.
Thanks, Sarah. Thank you, Chris. Can I ask colleagues please to indicate whether or not they are content to approve the new framework? Fabulous, thank you. And then finally, Mark and Karen, I think this looks like a double act. Item 9.2, review of funding, standing financial instructions and the scheme of delegation.
I'm going to ask Mark. I think we've agreed that Mark could introduce this paper. Thank you.
Excellent, thanks. Thank you, Mark.
Excellent. So good afternoon, everyone. So Mark Platts, Chief Finance Officer. So yeah, here to present the updated standing financial instructions and scheme of delegation. That both documents have gone through a thorough multidisciplinary review, which included Karen and the team, the contracting team, finance team, business development, a number of different professionals in the development of this. We are conscious to note that we will be requiring further updates as things like the new Procurement Act comes in February next year. It was due in October. It's slightly stalled now, so we're going to have to start to reflect all of that as they do come through. But certainly for the interim, a full review, and happy to take any questions on it. But it's here for a review. And sorry, I should have said it's also gone through the Best Use Resources Committee for approval.
Okay, thanks, Mark. So it's had several layers of looking at. If there are no questions, can I ask colleagues to indicate whether or not they're happy to approve?
So, sorry, Chair, I've got one quick comment from myself. It was the Audit Committee, not the Best Use Resources. It's my error. So apologies.
Yeah, no problem. I'm not sure anyone noticed, Mark, but for the purposes of the minutes, important to be clarified. So thank you. That takes us to the end. I haven't been notified of any other business. I don't have any other business. So we will draw this meeting to a conclusion. Thank you very much. We are due to meet in private immediately after this. I propose that we at least allow people to go off and have a cup of tea and a bun. It's now 12:15, so I suggest we reconvene it separately in private as private board in half an hour at 1:45. Thanks very much.
Thank you.
Thank you.